Hello, everyone. This is welcome to the live doubt clearing session for the MRCP Part 1 session. Kenny Sumboye. I'm the one of the rheumatologists with FAS Academy. And any questions that anyone has during this session, feel free to let me know. Either you raise your hands and the admin team will make me aware that you're there. So I'm pleased for the duration of the session, if you can just keep your microphone muted so that we don't hear any have any disturbances or interferences during the course of the session. So right, it's great to have everyone on. This again, this will be a very interactive session. So if anything is unclear or you're uncertain about anything, then do feel free to let me know. So we have a number of slides to get through. So the sooner we sort of get through it, then the better, so that we can get the best out of the session as much as we can. What I would try and do for the duration of the course is to give you tips, useful tips on how to tackle the questions that you will encounter during the course of the exam. And it's really about understanding the question at length and understanding what the question is trying to ask you. Some of the questions are designed in such a way that if you jumped in without giving it some thought, you can make mistakes. So you have to be quite careful about how you approach the questions. The questions have to be approached in a way where you get a proper understanding of what they're really asking of you before you then commit to the answer that you're trying to pick. If you jump in without necessarily being sure of what you're dealing with, you might find that you might end up with the wrong answers. So very important that you do the best you can in the right way and ensure that you get the best from the questions that are asked of you. Okay, so the first question is this. 20-year-old man is admitted with an episode of paroxysmal SVT, which required cardioversion after he collapsed at a nightclub. This is the second occasion he suffered from such palpitations over the last 6 months. He doesn't drink coffee and he doesn't take any illicit drugs, which is what he's mentioned to you from the history. His blood pressure is normal. His heart rate is just 85 per minute. It's regular. His chest is clear, and his BMI is adequate for his age. So you have some blood work in front of you. Platelet count is there. It's normal. Sodium is normal. You've done an ECG, and it just shows a shortened PR interval with the presence of a delta wave. What would be the most appropriate intervention in this sort of case? So is anyone happy to type in the chat what the right answer would be? They're happy with that? Just type in the chat what they would pick as an answer in this sort of case. Okay, so this sort of case, yes, absolutely. So yes, it would be radiofrequency ablation, and you're absolutely right. And you're right, it's Wolff-Parkinson-White syndrome, and you're absolutely spot on. And it is important that you do nail it in that regard. It's about knowledge of guidance, especially UK guidance. I always find that the Oxford Handbook is very useful in this regard, and that's something that you may want to sort of use as a tool to try and help you to answer these questions right. But yeah, that's a very easy one. So let's move on to the second one. So 18-year-old man is admitted to the emergency department with right upper quadrant abdominal pain. He's had nausea and vomiting. He's chronically anemic. He's had a problem with his red cells. It tells you from the history, which runs in the family. He's had episodes of abdominal pain, and he feels that this has increased over the last few months. Now, he looks pale when you examine him. He's got a bit of a low-grade temperature, 37.9. His blood pressure is fine. You've examined the abdomen, and he has pain in the right upper quadrant, and you also note that he has splenomegaly. So what you've done is you've done some blood work available. You've checked what the blood work is like, and you notice that he's got spirocytes on the blood film. White cells are slightly up, platelets are normal. The rest of the tests show that the CRP is quite high, and his bilirubin is slightly up as well. So what answer would you go with in this instance for this gentleman with spherocytes and raging CRP? What would you say the appropriate answer would be? Any thoughts, anyone? So this is a classic MRCP type question, very classic, where it can be a number of things. But the key thing about these sort of questions are that what you've been given is important. So they mentioned spherocytes. So the fact that they mentioned spherocytes means that spherocytes, it's actually important that you take into account that information. Now, why is it important? The fact that you can see spherocytes suggests that the red blood cells are abnormal. And if red blood cells are abnormal, that means that there's pigment formation. And if there's pigment formation, then it means that the likelihood that those pigments will enhance the formation of abnormal byproducts is very high. So the answer in this case is actually cholecystitis. So if byproducts are high, they're sludging, this kind of patient can go on to develop sludging in the biliary tract, and it can get cholecystitis, okay? So it's not Budd-Chiari. It's not Budd-Chiari because you've not been told anything in that regard. You've not been given any history, any details within the history to make you think Budd-Chiari. Epstein-Barr virus, you've not been told is immunosuppressed, so it really can't be that. With Gilbert syndrome, the patients are usually well. You wouldn't have a raging CRP of 220. And hepatitis A, you've not been told that he's had something through the fecal-oral routes. So this is how you exclude the answers that you don't really need. So the key to this question is use the information you've been given. If you've been given information, use it. There's a reason why you've been told spherocytes are identified. And that's really the key to this whole question. Anyone happy with that? Any questions? Is everyone happy for us to move on? Okay. So that's the key to that question. So let's move on to the next one. So next question. So 18-year-old woman who's presented with, 18-year-old woman who's sitting our end of school exams, reviewed in the first seizure clinic. She suffered a generalized tonic-clonic seizure about 2 to 3 weeks ago. While she was walking to school. You understand from her and her mother that she has suffered increasing clumsiness in her upper limbs, particularly in the morning. She seems to suffer some involuntary jerking, and they feel that this jerking movement is getting worse, particularly when she's sleep deprived. She's fine in terms of normal attainment in university. You've examined her neurologically. There's nothing to find. She struggles to gain a bit of weight. The neurological exam is completely normal. You've done an EEG, which was done the previous week, and it shows a frequency of a bilateral polyspike slow wave discharge with a frequency of 46 hertz. Which of the following therapies would benefit this kind of patient? What answer would you go with about this sort of patient with a frequency, slow spike wave frequency? Any answers from anyone? Okay, so let's see. Okay, so Dr. Chowdhury went with A. Any other person on what the answer might possibly be? So Dr. Chowdhury, if you can type what you think the diagnosis is, because the key to this question, if you really want to get it right, you have to really consider a diagnosis to start with. So what do you think the diagnosis is, Dr. Chowdhury? Can you type what you think the diagnosis is in the chat? Because that really is the key. If you nail what the diagnosis is, then you'll be absolutely certain on why you picked carbamazepine. I mean, obviously, carbamazepine can be used for a number of seizures, but the key to this sort of question is really getting an appreciation of what the diagnosis is. So the diagnosis in this case is actually JME, that's juvenile myoclonic epilepsy. And if you know that it's JME, the diagnosis in this case, I mean, the treatment of choice will be levetiracetam. So JME is the actual answer. And if you know that JME is the answer, you don't really use carbamazepine to treat JME, which is juvenile myoclonic epilepsy. You actually use levetiracetam. That is the key. So this, again, is another typical MRCP type question. And the key is to pay attention to the fact that what was found on the EEG and also you need to pay attention to the fact that the jerky movement she has is quite key. So the feature found on EEG is quite classic for what you would find in JME. And those jerky movements, you need to take that into account. Again, this is one of those cases where what you've been given is important that you do use it. Any questions or